Good evening, ladies and gentlemen. It gives us immense pleasure to welcome all of you to this lovely Sorabara village. Isn't it, Dhwani?
Couldn't have agreed more. We welcome you all to the 8th session of Academic Hour continuing Professional Development Lecture Series organized by the Clinical Society Base Hospital Mahiyanganaya, together with the Branch Union of Government Medical Officers Association. So just the other day, as I was preparing for tonight's event, I was looking for quotes and stumbled upon some eye-opening post online. This one that touched my heart was the one that a mother had posted online. It said, "The kind of person we come across our pregnancy, delivery and the postpartum will decide who we hate and love for the rest of our lives." This made me realize how important tonight's topic is. Isn't it, Udari?
So very true. For every mother and baby care, what we've got to really think about is how can we as health professionals do our best. So today we will focus on a very essential topic in obstetrics, inverting the pyramid of antenatal care, which will be conducted by our very own consultant obstetrician and gynecologist, Dr. Janaka Jayasinghe.
This kind invitation goes to the President of Clinical Society, Consultant Physician Dr. Rohitha Amaravikarana, to introduce our speaker for tonight. Over to you, sir.
Good evening. You all are welcome to the second major session, academic session organized by Mahiyanganaya Clinical Society. So first I would like to thank the council members and organizing committee as well as our sponsors, and especially Dr. Janaka and gynecology team organizing this excellent session. So let me to introduce today's speaker, Dr. Janaka Jayasinghe. I am sure this audience needs no introduction about Dr. Janaka Jayasinghe because he worked in our hospital more than 4 years as consultant gynecologist and obstetrician. To introduce today's speaker, Dr. Janaka Jayasinghe, consultant gynecologist and obstetrician, Base Hospital Mahiyanganaya. Also, he is the president of the branch union of GMOA. Dr. Janaka Jayasinghe, MBBS Peradeniya, MD Obs and Gynae Colombo. He graduated from the University of Peradeniya in 2003 and obtained his MD Obs and Gynae from University of Colombo in 2014 and MRCOG UK in 2018. He completed his overseas training at Leeds Teaching Hospital, NHS Trust, United Kingdom. He worked as many hospitals. He worked in many hospitals in Sri Lanka as a consultant gynecologist and obstetrician, including BH Pothuwil, Mahawaya and Rikilagaskada. He is going to talk on inverting the pyramids of antenatal care. So you know that as a traditional medicine and also current practice, we know mostly antenatal care concentrated on the third trimester and with the advance in the pregnancy. But current evidence and guidelines mostly concentrated this pregnancy care should be started at the beginning, because a lot of complications we can see with the first pregnancy, and a lot of things to learn today from Dr. Jayasinghe. And may I cordially invite Dr. Jayasinghe to talk on inverting the pyramid of antenatal care. Over to you.
Thank you, Rohit, for your kind introduction. Good evening, everybody. And it's a great pleasure to address this audience. And I am going to talk about inverted pyramid of modern antenatal care. I think when I got this opportunity to deliver my speech, I was thinking what I am going to speak, what I am going to talk. I initially thought of focusing GPs and peripheral doctors doing something topic related to obstetrics. But ultimately, I decided to discuss this topic. It is more obstetric related. I know this audience is not 100% obstetric related, but this is to make you awareness of the current obstetric practice of inverting pyramid of modern antenatal care. Right, during my talk, I would like to cover what is the current practice. It is the old antenatal care model, and what is the new concept, inverted pyramid. And especially focus on diagnosis and screening procedures, that is novel method that is introduced into the care model, and a little bit about second trimester and third trimester, and we'll discuss, or we'll there is some time for the questions. Right. Antenatal care, it is a comprehensive health supervision which includes history-taking, examination, observation, and guidance from the conception to the delivery. Initially in 1929 in UK, they produced a traditional care model. This traditional care model, they focus pregnant women to meet professionals roughly around 12 to 14 visits. During that period, when the pregnant mother is getting advanced in her gestation, they notice the mother is developing some diseases such as pregnancy-induced hypertension, gestational diabetes mellitus, and the baby is getting small for gestational age. Therefore, they thought, all right, the risk and the complications are more detectable during the latter part of pregnancy. During the first trimester and second trimester, they thought, all right, pregnancy is smooth, it is smoothly going. Therefore, they focus more on the latter part of pregnancy. Therefore, they make a model considering these facts, increase surveillance of the mother on the latter part of pregnancy. They start surveillance from 12 weeks, then monitor the mother every 4 weeks time up to 28 weeks, then 2 weekly from 28 weeks to 36 weeks, then weekly from 36 to delivery. Therefore, mother has to go to health professional more frequently during the latter part of pregnancy. Right. Then in 2011, Prof. Gynaecologist from United Kingdom introduced the new concept of inverting the pyramid of antenatal care. Then the background was that he thought that there are medical conditions which can be detected in the latter part of pregnancy. But he thought, can we detect, can we suspect, can you predict these complications in early trimesters? With the advance of medical knowledge and technology, he make a model, right? We'll screen mother during the first trimester, which are more prone to get adverse effect during the latter part of pregnancy. Therefore, he focused in the first trimester, especially from 11 weeks to 14 weeks, to identify the risk population that is going to have complications and intervene those population to prevent occurrence of adverse effect or minimize the adverse effect, like minimize the effect of complications. Therefore, the high-risk populations get into the separate group and manage as a specialized care. Right. This is the inverted pyramid of antenatal care. The key thing is the 12-week fetal evaluation. In the first trimester, end of the first trimester, 12-week fetal evaluation, they targeted to identify most of the complications in 12 weeks fetal evaluation. And then they categorize the patients into who need specialized care and who can be followed up in the primary care setting. And then routine follow-up. Right. Then the base of the pyramid is first trimester, then tapering from the second and third trimester. Right. When we move into this pyramid, inverted pyramid, right, first trimester evaluation mainly focus on dating, aneuploidy screening, and screening for multiple pregnancy and its complication, screening for uterine and adnexal pathologies, screening for medical conditions such as gestational hypertension, preeclampsia, DDM, diabetes in pregnancy, anemia, DVT, and screening for small for gestational age, and screening for preterm birth. Therefore, at the booking visit or the first, when the patient first come to the healthcare professional, this screening was focused on whether there is any whether she developed any pregnancy complications, whether the baby developed any fetal complications, or whether the mother can get complications. Right. In the first trimester, the key thing is the first trimester dating scan, which was implemented in the routine model also. Usually we do it from the 11 weeks to 13 plus 6 days using the crown rump length. The baby should be 45 millimeters to 84 millimeters in size. And this is the key thing that should be done in the antenatal care, because correct dating can minimize prematurity and post-maturity, and it helps us to reduce intrauterine. After dating, which was in the routine antenatal care package, then Prof. Nicola focus on how do we can screen or how do we can predict the future diseases in this mother. Out of that, aneuploidy is the first thing that we are going to do. Aneuploidy screening, sorry for that letters in the ups. Aneuploidy, usually they focus in Down syndrome, Patau, and trisomy 18, Edward syndrome, and also Turner syndrome. Therefore, risk identification of aneuploidy focused on mainly the maternal age and some ultrasound markers. Ultrasound markers, they focus on neural tube, nuchal translucency, nasal bone, and ductus venosus Doppler and tricuspid valve Doppler. And then they focus on some biochemical markers such as placenta associated polypeptide A, HCG, placental growth factor, alpha beta protein, inhibin A, and estradiol. Right. We'll see, this is the graph for age. Age is the key thing that affects aneuploidy. When we consider trisomy 21, I think it's not clear for you. Trisomy 21, the age, when we consider the age, the risk of the baby getting Down syndrome at the age of 25 is 1000 in 12 weeks, and it is 1400, 1 in 1400 in 40 weeks. That is, at 12 weeks, the more down babies are there in the mother's tummy, but some get aborted. Therefore, the risk is more in the 12 weeks, and it is 1,000. But live birth, it is 1 in 4,400. When we consider the 35 years that we usually consider an advanced maternal age, it reduced to 250 in 12 weeks and 350, 1 in 350 in 40 weeks. Therefore, Down syndrome, occurrence of Down syndrome markedly increase at the 40 weeks by 35 years. Then from 35 age of 35 and onward, it gradually increased. By 40, the occurrence of Down syndrome is 1 in 100. And at the 12 weeks, it is 1 in 70. Trisomy 13 and 18 also same. They have a positive association with the age. And at the age of 35, the occurrences of Edward syndrome is 4,200 and the trisomy 13 is 10,000. The special thing in aneuploid is Turner syndrome. It is not associated with maternal age. Therefore, solely from the age, we can classify, we can categorize whether this is a risk mother for aneuploidy or not. Then these risk mothers, then we can direct them into ultrasound markers. The first and key ultrasound marker is the nuchal translucency. The nuchal translucency is the fluid collection. Nuchal translucency is the fluid collection behind the baby's neck, which is detected from the ultrasound scan. We do it from at the gastration of 11 to 13 plus 6. Therefore, we can combine this nuchal translucency measurement during our dating scan. Usual our cutoff is 3.5 millimeters. That is, even though with the advancement of gastration from 10 weeks to 14 weeks, there is slight increment of the nuchal translucency. The maximum cutoff is 3.5. Therefore, if it is above 3.5, they are more prone to get chromosomal abnormality. Also, not only the chromosomal abnormality, the increment of the nuchal translucency is associated with some structural abnormality also. The common things, congenital diaphragmatic hernia, omphalocele, cardiac defects, and facial defects. The other thing is, after the nuchal translucency, usually when we do ultrasound scan, we check the fetal heart rate. We won't find out whether the fetal heart is there or not. But during the dating scan, we can measure the fetal heart rate. Measurement of fetal heart rate is important, and usually fetal heart rate varies. At 5 weeks it is around 110, and by 10 weeks it is 117, and then gradually decreasing to 150 by 14 weeks. And in trisomy 21, the fetal heart rate is mildly increased, and it is above 95th centile in about 15% of cases. And in trisomy 18, fetal heart rate is mildly decreased, and it is below the 5th centile in about 15% of cases. And the special thing is trisomy 13, that is Patau syndrome. The fetal heart rate is substantially increased and is above the 95th centile in 85% of cases. Therefore, if the fetal heart rate is above the 95th centile during the first trimester at the time of dating scan, the patient there is a 85% of baby having trisomy 13. Therefore, we can give some more time with the ultrasound scan with the patient, and we can focus on the fetal heart rate, and we can, it will be useful to for risk categorization of the patient. Right, those are the main ultrasound, simple ultrasound markers to identify the risk population for aneuploidy. Then comes the biochemical markers. The biochemical markers that we commonly use are free or total HCG, kappa A, alpha beta protein, unconjugated estradiol, inhibin A. Using these markers, we do the combined test in the first trimester. That is, we measure the nuchal thickness or nuchal translucency, and we measure HCG and kappa A. Using those three parameters, we can detect 82% of trisomy 21 during the first trimester. Therefore, we implement the combined test in the first trimester to assess the risk of the baby getting Down syndrome. If we miss the first trimester, if we catch the patient in the second trimester, we can do the quadruple test, which include alpha beta protein, unconjugated estradiol, HCG, inhibin A. And using those four things, we can categorize the patient into as trisomy 21 in 64% of patients. This is not a simple process. There are algorithms which we can categorize the risk. We can do it in Sri Lanka, and with the lab, when we send the sample to the lab, they will categorize the risk and they will send up the percentage of risk that the baby is getting Down syndrome. Similar thing, we can, using these biochemical markers, we can assess the baby whether she is having trisomy 13 and 18. Right. Out of those commonly used markers, the other thing that we can do is, using the ultrasound scan, we can further evaluate the baby. One thing is the baby's nasal bone. It is a simple thing in the babies. When we check the babies in the left lateral position, we can see the nasal bone. As the pointer indicates, nasal bones is just above the baby's mouth. And usually we see the nasal bones hypoechoic area. But if the nasal bone is absent during the period of 11 weeks to 13 weeks, the usually euploid fetuses, normal fetuses, they are absent only in 1 to 3%. Fetuses with trisomy 21, there is a 60 baby is having absent fetal nasal bone. The chances of baby getting trisomy 21 is 60%. And the fetal bone is absent, there is a 50% chance of baby getting trisomy 18 and 40% chance of baby getting trisomy 13. The next thing is ductus venosus Doppler. We know the ductus venosus, which carries the blood into the through the liver into the baby's IVC, inferior vena cava. The first diagram show the pattern of ductus venosus Doppler. There are three waves. Out of that, A wave, we are considering about the A wave. And if the A wave is reverse, there is more chance of baby getting fetal anomalies, more chance of baby getting aneuploidy. If we detect the reverse A wave in ductus venosus Doppler in first trimester, the baby, there is a 65% of baby having trisomy 21 and 55% of trisomy 18 and 55% of trisomy 13. Then further evaluation of the babies using the ultrasound scan, we can assess the blood flow through the heart valves. And if we detect the tricuspid regurgitation, if the blood regurgitate during systole, if we see the tricuspid regurgitation, There is 55 chance of baby getting trisomy 21, 30% chance of trisomy 18, and 30% chance of trisomy 13. Sorry, 18 and 13. Those are the main biochemical and ultrasound markers that we can we can predict aneuploidy. Then, according to those markers, we can categorize again the baby. We can categorize the baby into high risk, intermediate risk, or low risk. If the baby is categorized into high risk, they need the definitive diagnosis, which include chorionic villi sampling. If it is an intermediate risk, we can use, after the initial categorization, we can use that soft markers such as tricuspid regurgitation, nasal bone, and those markers. If still high risk, we can go for chorionic villi sampling. If goes into low risk, we can follow up the patient with ultrasound monitoring. Usually we can do the next ultrasound scan at 20 weeks. That is the first thing, that we screen taking some time with the patient, doing the ultrasound scan. We can categorize the patient whether she is high risk for aneuploidy or whether it is low risk for aneuploidy. If the high risk, we can go for further evaluation. The second thing that we can evaluate is the structural abnormalities. In the previous days, in the all antenatal care model, we thought the anomaly scan is at the 18 to 22 weeks gestation. We don't want to bother in the first trimester. No. This is the new concept with target 9. Target 9 is the 9 main structural abnormalities can be detected during the first trimester ultrasound scan. The common thing are acrania and encephaly. You all know the first picture. First picture is the frog sign, that is anencephaly, and anencephaly, that is a neural tube defect with the absence of occipital bone, and the baby is hyperextended. The second one, these are commonly seen, not commonly, they are easily diagnosed in the first trimester scan. And the encephalocele, the defect in the occipital bone, and alobe holoposencephaly, that is single eye and facial defect, omphalocele defect in the abdominal wall, and gastroschisis mainly detected in the abdominal wall. Megacystic, it's megacystic, it is the distended bladder, limb reduction defect, and body stalk abnormality. Body stalk abnormality is absence of anterior abdominal wall. These 9 structural abnormalities can be quickly detected during the first trimester ultrasound scan. Therefore, taking some time with the scanning with the first trimester patient, we can find out these abnormalities. Right. Thinking all those things, then this is the novel evaluation. It is cell-free fetal DNA. I think you may have heard, it is called ANOVA test. During the growth of the baby, the fetal DNA, free DNA, goes to maternal circulation. Therefore, when we get the maternal blood, there is some proportion. There is a proportion of DNA, free DNA, in the maternal circulation. Therefore, it usually occurs after 10 weeks. Usually from 10 weeks onward, there are some proportion of fetal DNA in the maternal blood. Therefore, people thought, all right, we'll get maternal blood, we'll get the DNA, and we'll assess this DNA, then we can detect a lot of chromosomal abnormalities of the baby. That is called cell-free fetal DNA, called ANOVA test. This is more sensitive test. 99% of the fetal trisomy 21 and 98% of the trisomy 18 and 13 can be detected from this test. And the false positive rate is very, very low. It is 0.1 to 0.2%. Apart from that, it is very helpful to identify the, now it has developed to identify the sex differentiation as well as the sex aneuploidy. And it is more advancing now, cell-free DNA is more advancing now, they are targeting some chromosomal genetic abnormalities to find out from this test. There is certain microdeletion such as 22q11D George syndrome. Now it is helpful to you diagnose this. Right. If now I told you that in the maternal blood we check the fetal free DNA. This is the simpler, non-invasive to the baby. Therefore, it is easily performed, but it is very expensive. It costs roughly around in Sri Lanka 60,000. But it is very helpful. If the cell-free DNA test is positive, what we have to do is we have to confirm it. I told it is 99% sensitive, but there is a 1% chance of miss. Therefore, if there is we say Patau syndrome, Edward syndrome, if we go to intervene because of the test, we are not going to intervene from the cell-free DNA. We have to go for invasive tests such as chorionic villi sampling if we are going for termination or something else. Therefore, if the cell-free DNA results is positive, we have to go for invasive test. If it is negative, we can go for ultrasound surveillance. Right. If the routine is screening by first trimester combined test, I told you the combined test, nuchal translucency and biochemical markers. If it is positive, if the patient is in high risk, we have to go for invasive test. If the patient is intermediate risk, we have to go for cell-free DNA. And if it is positive, again we have to go for invasive test. We don't jump into invasive test because invasive test carries some risk of miscarriage, and it is discomfort to the patient and some risk of bleeding, infection and those things. If the screening by age, ultrasound and or biochemical, if the high risk, we have to offer cell-free DNA. If it is positive, we go for invasive test. Right. That is about cell-free DNA. Right. Then those are the main markers in the for detect main markers and the test available to detect aneuploidy. It is, we have to get some more time. It is debatable to whether we can implement into the government hospital, but if in case we can assess the well-being of the fetus in the first trimester using those. Next come the next thing is the when there is twin in the first trimester, it is very important, and main thing is twin in the first trimester is the assess the chorionicity and amnionicity, because the next follow-up plan totally depend on the chorionicity and the amnionicity. Because we treat dichorionic diamniotic in separate pattern and monochorionic monoamniotic or monochorionic diamniotic in separate pathway. Therefore, evaluation of the placentation and chorionicity is important in twins. Right. Those are the main things in the aneuploidy and twins. Now we come to whether we can predict maternal and fetal complications which may be occurred in the latter part of the pregnancy from the booking visit. Screening of preeclampsia. Therefore, the researchers targeted about eclampsia, preeclampsia. Why preeclampsia? Preeclampsia because globally there is 500,000 of fetal and neonatal death due to preeclampsia. And still in the world there is 70,000 of maternal death due to preeclampsia each year. Therefore, the researchers focused, if we can predict preeclampsia, if we intervene or start some treatment or intervention, First thing, we can prevent occurrence of preeclampsia, or we can minimize the complications of preeclampsia, or can delay the occurrence of preeclampsia. The next thing is small for gestational age, and the background for these things is the most placental architecture, including placental maternal blood circulation, is established at the end of the first trimester, because that SGA baby, small for gestational age babies, they depend on the SGA development, occurrence of SGA mainly depend on the placental circulation. Then the most placentation take place is completed by 16 weeks. No further anatomical modification now evident after the 4th month of pregnancy. To reduce the risk of complication related to placental dysfunction, it must be instituted early in pregnancy. Right. Now we will discuss a little bit about preeclampsia. How do we detect, or how do we identify the patients who are prone to get preeclampsia? The risk identification mainly depend on maternal risk factors, uterine artery Doppler, placental growth factor, and some soluble FMNs like tyrosine kinase receptor and risk prediction models. There are several types. Right. Simple things. How do we detect preeclampsia from the maternal factors? There are risk factors for the mother, major risk factors and the moderate risk factors. If the mother is having type 1 or type 2 diabetic, chronic hypertension, hypertension during the previous pregnancy, chronic kidney disease, autoimmune disease such as SLE, antiphospholipid. Those are major risk factors. If the mother is pregnant mother is having these risk factors, we consider them as major risk factors, and there is a high chance of mother getting preeclampsia. Moderate risk factors: pregnancy intervals more than 10 years, and age more than 40, BMI more than 35 at booking, family history of preeclampsia. Usually we don't ask whether the mother had, we have to ask from the patient whether your mother had preeclampsia, and multiple pregnancies. Using these risk factors, if there is one major risk factor or 2 moderate risk factors, no use of doing nothing, identification only, no use. We can prevent occurrence of preeclampsia by starting aspirin. I'll discuss the dose and this later. The next thing, yes, if the mother is not having any risk factor for preeclampsia, the next thing is uterine artery Doppler. It is done in the first trimester. Assessment of uterine artery Doppler, we can predict preeclampsia. Early onset of preeclampsia 81%, and late onset preeclampsia 45%, and gestational hypertension is 50%. Therefore, checking the uterine artery Doppler and the uterine artery Doppler abnormality per se can predict 80-81% of early onset preeclampsia. Therefore, if the mother is not having maternal risk factors for preeclampsia, we can predict it by using the uterine artery Doppler. Apart from that, history, uterine artery Doppler, and biochemical markers, which I am going to be discussed later, will predict 96% of preeclampsia. Therefore, the risk can be derived from maternal history and any combination of biomarkers. Useful markers at 11 to 14 weeks are mean arterial pressure, uterine artery pulsatility index, and serum placental growth factor. Those 3 markers, using those 3 markers, the prediction rate is very high. This is not a just simple thing. We can use these things, and the family medicine unit in UK, there is a website. In website there is a format. We have to fill those things in this format for the patient age, parity and those things, then they will give us the prediction rate for preeclampsia in this patient. Therefore, with the prediction rate, if the prediction is very high, if the risk is very high, we can take the preventive measures. Right. This is about preeclampsia. Now we will move into small for gestational age or IUGR babies. Are there risk factors? Is the mother having risk factors for the baby to have SGA? Yes. Similarly in the preeclampsia, here also there are major risk factors and minor risk factors. Major risk factors, the common things are advanced maternal age, that is 40 years or above, and if the mother smokes more than 11 cigarettes per day, and if there is a paternal SGA, drug addicts, and who is doing vigorous exercise, and who has delivered a previous SGA baby, previous stillbirth, and who is having chronic hypertension, diabetic, renal disease, antiphospholipidism, some medical condition. If these major risk factors mother is having, there is a high chance of baby giving SGA. And there are some minor risk factors, that is maternal age more than 35, IVF singleton pregnancy, nulliparity, BMI less than 20, and who smoke 1 to 10 cigarettes per day, and there are some other things. Okay. By using this risk identification model, we can categorize the mother is she more prone to get SGA baby or not. Then if there are 3 or more minor risk factors, we have to do uterine artery Doppler. This is uterine artery Doppler at 20-24 weeks. Then close surveillance. If there is an abnormal, we have to close surveillance of the mother to assess whether baby is developing SGA. And if the risk factors are there, as I told earlier, prevention of preeclampsia, we can start aspirin here also to prevent or minimize the occurrence of small for gestational age. Right? In summary, the parameters mainly used to screen for SGA is uterine artery pulsatility index and maternal mean arterial blood pressure. And the other chemical parameters are serum papa, beta HCG, placental growth factor, and placental protein 13 and other things. Right. Combination of these markers along with maternal characteristic detection rate is 75% of the fetuses delivering before 37 weeks and 45% that deliver at term. Therefore, using these markers, we can detect the babies who will be delivered before 37 weeks, about 75%. But there is some false positive rate of 10%. That is about SGA. For the SGA as well as the preeclampsia prevention, the key thing that we are doing is monitoring and administration of aspirin. The other thing is, even though this is not common in Sri Lanka, it is more common. DVT is more common in foreign white population. Therefore, screening for DVT also very important in the first trimester. Pre-existing diseases such as previous venous thromboembolism, and if the mother is having thrombophilia, heritable or acquired, and mother is having some medical comorbidities, and the age is more than 35, if the mother is obese, and parity more than 3, smoking, and varicose vein, and paraplegia. And other obstetric risk factors, mother is having multiple pregnancy, current preeclampsia, and the mother is going for cesarean section due to prolonged labor. These are in the third trimester, and stillbirth, preterm labor, postpartum hemorrhage. They are more prone to get DVT. Therefore, using these risk factors, we can categorize this we can score them. If the score is 3, we have to give heparin from 28 weeks onward. And if the score is 4, we have to do heparin, enoxaparin throughout pregnancy. And postnatal, we have to complete either 10 days or 6 weeks. Therefore, first trimester evaluation of the risk factors for DVT help us to start enoxaparin and prevent occurrence of DVT. The other main thing is preterm birth. We know pediatric team is very distressed about preterm birth. Therefore, can we predict spontaneous preterm birth? The prevalence of preterm birth is number one cause of perinatal morbidity and mortality, responsible for 35% of the world's 2.6 million neonatal deaths occurred in 2016. Not only the neonatal death, there can be lifelong effects such as neurodevelopmental delay, cerebral palsy, intellectual disability, visual and learning impairment, and chronic diseases in adulthood. Therefore, preterm birth is a burden to the society. Therefore, the researchers focus, can we predict this and can we prevent this? Yes, the first trimester, using ultrasound scan, we can measure the cervical length. Therefore, in the first trimester, while doing the dating scan, we can assess cervical length. If the cervical length is short, usually we consider as 25 millimeter or less, there is a high chance of the baby going to preterm birth. To prevent that, we can re-scan in 2 weeks or 4 weeks time and assess whether cervix is shortening. If the cervix is become shortening, there are two options that we can do is, one thing is we can offer a cervical circlet, that is a stitch applied to the cervix to prevent preterm birth, and on the same time we can give them micronized progesterone vaginally to prevent shortening of cervix. Therefore, using these two parameters, it is very helpful to the baby to having a preterm birth, preventing a preterm birth. Right. Yes. Then we'll move forward, and the other main thing is diabetes. Diabetes in pregnancy. It's usually occurred after 28 weeks. Then the people says, can we predict it earlier? Or can we diagnose it earlier? Because gestational diabetes mellitus and chronic diabetes mellitus, which has not been detected previously, has a great impact to the mother and the baby. Baby may become large if it is uncontrolled, and there is a chance of stillbirth, and there is a birth problems if the baby is large. Therefore, they identify some risk factors for GDM, gestational diabetic mellitus, which can be evaluated in the booking visit. If the BMI is above 30 kilogram per square meter, and if the mother has delivered a previous macrosomic baby, that is more than 4.5 kilogram baby, and if the mother had previous gestational diabetic mellitus, and if the mother is having a family history of diabetes, specifically relatives with diabetic, or some ethnic prevalence, usually Asian population is considered to be having more prevalence of diabetes. Therefore, if the mother is having these risk factors, they are more prone to get diabetic in pregnancy. Diabetes in pregnancy can be either gestational diabetes or hyperglycemia diagnosed for the first time during pregnancy, that meet the WHO criteria for diabetes mellitus in non-pregnant state. Therefore, non-diabetic patient can be first detected as diabetic during pregnancy. Yes, how do we screen for this one? If the risk factors are there, the recommendations are, if the risk factors are there, all the patients should be undergone 75 gram oral glucose tolerant test at the booking, and if it is normal, we have to repeat at 24 to 28 weeks. If there is no risk factors, we can offer a screening test at the booking, such as PPBS or glucose challenge test. And if it is negative, we can do the OGTT at 24 to 28 weeks. I think we are now practicing this one, but there is less chance of people are doing OGTT at the booking visit, even though the risk factors are there. Right. The next thing is anemia. The anemia is big prevalence in Mahiyanganaya area. We do full blood count. We do assess hemoglobin in the first trimester as a routine screening test. But it is better to encourage women to do full blood count, which include all the other parameters. Most of the time I may see they are having done only the HB, not the full blood count. Therefore, assessing the full blood count, we can get more information about the blood levels and whether there is more prone to get hemoglobinopathies such as thalassemia. Right, that is the inverted pyramid. Which I discussed was the 12-week fetal evaluation. It is the broad base. We have to do hard work during the 12-week fetal evaluation. After this evaluation, we can categorize these patients whether she is more prone to get aneuploidy, more prone to get gestational diabetes mellitus, more prone to get preeclampsia. After evaluation, we can direct these patients whether she can have a primary routine care or whether she needs a specialized care up to 37 weeks. Then moving into second trimester, now the big task that we have finished. Now moving to second trimester, there are less things to do in second trimester. The main focus is the fetal anomaly scan, which should be done from 18 to 22 weeks. And we can detect, I told that we have detected target 9. We have 9 anomalies we have detected. Rest of the things we can detect from anomaly scan. Overall sensitivity is around 60 to 70%. The other thing is we have to identify the placental pathologies. There are two main types of placental pathologies: placenta previa, that is lower line placenta, and placenta accreta, ingrowing of the placenta into the uterine myometrium. The lower line placenta or placenta previa in the second trimester, mid trimester scan is doesn't give any clinical value, but it is important to detect it and do a follow-up scans. As well as if there is suspicious of placenta accreta or percreta, we have to further evaluate in the second trimester scan. Right. Those are the main thing, and then moving into third trimester. Now we have made the platform for the patient to go. Therefore, rest of the things we have to smoothly follow up this patient. Therefore, no any additional risk assessment is needed during the third trimester. Only thing is we assess the serial fetal growth assessment, and we assess the maternal blood pressure, blood sugar monitoring, and be ready with the accepted neonatal complication. Therefore, we have to watch and see during the third trimester. At the third trimester, key things that we have to do is where do we going to deliver, what is the mode of delivery, and when we are going to deliver. Place of delivery depend on the requirement of the maternal and neonatal facilities, and the mode of delivery according to the risk assessment of the baby and the mother, and time of delivery, and which is no longer safe in the intrauterine life, we have to deliver. That's all. Now we have brought the mother from the conception to the delivery. Hope you understood something at least. Right. We'll have some questions.
Using this cell-free fetal DNA test. And the second question is again.
Sorry, I didn't get the first question.
What are the common diseases you can detect using this test? And the second question is, do you advise to do it as a screening test, or are there any indications to do the cell-free fetal DNA testing?
Yes. The main thing now, they have formed the, I think, kit for screening detection of Downs, Patau, Edward, Turner's, and sex chromosome abnormalities, and few other chromosomal deletions, 2 or 3 chromosomal deletions. Not much. They have made kit. Therefore, it is detectable with 99% sensitivity and false positive rate of 0.1%. In our setup, we don't offer because it is very expensive, 60,000 per check. In UK, they offer as a screening process. But it is not mandatory. As I showed in the graph, if the age and the ultrasound markers are suspicious and patient put into high risk, then we can offer, sorry, not the high risk, intermediate risk, we can offer cell-free DNA, not to the all. Did you get my point?
Yeah, thank you very much. And you say, what is the cost for this test? Cost, you say?
Yeah.
60,000 rupees.
60,000 rupees in Sri Lanka.
Thank you.
But it is very cheap in India.
How much?
It is 9,000 Indian rupees. That means
Multiply by 3.
30,000 now.
Yeah. Thank you.
Actually, my target was to make you aware about the available resources that you can implement or you can do. I requested most MOHs to come.
To implement sort of practice, especially when we are working in this hospital, we are working in hospitals where are lack of resources. So generally, did you practice this whatever the inversion of this pyramid of antenatal care now, generally in periphery, or whether what are the things you are doing nowadays? Because we have lack of technology now.
Yes. The main thing is not only the technology. The main thing is how much time we can give to one patient.
Yes.
For the dating scan. If usually it is recommended 30 minutes for the patient for 12 weeks evaluation. 30 minutes, minimum 30 minutes. Because nuchal translucency, as I told you the picture, the baby should be in the neutral position like that. Usually when we do the probe, we may keep the probe, baby is not in the neutral position, baby blah 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 like that. Therefore we have to wait for 1 to 3 minutes on keeping the probe to get the baby into neutral position. Therefore the main thing is the workload. If we can at least give 30 minutes to the patient at the 12 weeks, we can cover a lot of things, mainly ultrasound markers. The next thing is, this is, even though this is practicing in other countries, this is, the next thing is technical knowledge or skills, how to detect nuchal, how to do nuchal translucency, and how to do tricuspid visualization, Doppler activities and those things. Therefore, most of our hospital, peripheral hospitals have scan. Therefore, we can easily implement.
Those scans is adequate?
Yes. The most available scans in Mahiyanganaya, it's good. There are Sario 200, it's good scan. I think most of the hospitals have good scan. The previous hospital, that old scan machine has been replaced now. Therefore, time and skill need to be improved. Then we can implement. The rest of the cell-free fetal DNA and biochemical markers such as placental growth factor and assessment of those things will take money, but at least we can categorize some risk, and if the patient is affordable, we can offer them to do. Especially if the age is 40 years of age, and if you do the nuchal translucency, if it is high, we can offer them to have cell-free DNA. Another drawback is, even if we detect trisomy 18, we can't abort. In foreign countries, in other countries, they can go for termination. But here, there is some problem with that. But I don't think that abortion and termination is a termination answer. But however, we should assess, we should inform the patient. Now patient is growing the baby with knowledge. Now mother knows my baby is having Down syndrome. Now I must be ready for that. Then mother's psychology is ready to accept a Down syndrome baby after delivery. That's what we can do. I told you implementation is easy, but need time and skill. Okay. Prabhat, no questions.
One question regarding cell-free DNA. Do you have any idea how they detect the chromosomal anomalies by doing by checking the DNA, cell-free DNA?
Yes. But the thing is, when they get the maternal blood sample, there are clusters of DNA, clumps clumps of DNA, right? Which are not maternal. I have seen some pictures. When the blood film is there are clumps. Some clumps fetal, some clumps maternal. They can easily find out maternal things. So maternal blood, get the maternal blood sample, maternal WBC, and assess their DNA. Then rest of the things they consider fetal. Therefore, they get fetal DNA. Then they analyze those DNA. Therefore, those clumps, sometimes all 23 or 46 chromosomes may be there, sometimes not all. They have to get so many clumps and arrange to get 46. Okay. Thank you very much. In the absence of questions, we will find out.
Thank you, sir. We are sincerely grateful for sharing your gifts and knowledge. Your expertise and insights greatly enrich the experience for our attendees, and we are truly thankful for your valuable contribution.
Uday, shall we move to the next most anticipated segment of tonight's event, the quiz? I'm hoping to see more enthusiastic participation from attendees tonight. The questions will be there on the screen before you, and each question you get 45 seconds to answer. Kindly request everyone to join this Zoom session. I will join myquiz.com. Please do so to answer. Is everyone logged in? Can we proceed? Is everyone logged in? Do you need more time? Okay.
And our winner is none other than Dr. Sanjeeva Niroshan. I kindly request Dr. Janaka Jayasinghe to present the gift to the winner. The token of appreciation to Dr. Janaka Jayasinghe will be presented by Dr. Senal Medagidara on behalf of the Clinical Society. Thank you, sir.
As we come to the end of tonight's session, let us take this opportunity to thank all who supported us.
First of all, to our speaker, Dr. Janaka Jayasinghe, and the Obstetric and Gynecology team.
Government Medical Officers Association Branch Union for their constant guidance and support, and our sponsors for tonight, Gamma Interfarm. I kindly request Dr. Janaka Jayasinghe to come up and have a little speech regarding give a brief question. Sorry, sir.
No need to discuss, it's very easy questions, no? Ideal timing of the dating scan? 11 to 13 plus 6. Before 14 week, no. The ideal time is 11 to 13 plus 6 using the crown rump length. Parameters not used to assess the risk of aneuploidy. Nuchal transfer we use, maternal age we get it, fetal nasal bone as day 21 progesterone. It is used to detect ovulation. Increased nuchal translucency, it is associated with Down syndrome, and more than 3.5 millimeter implies baby may have got structural abnormalities. Mature before 14 weeks. Yes, it's mature 11 to 13 plus 6. It is not associated with congenital diaphragmatic. Yes, it is associated with some structural abnormalities such as diaphragmatic hernia. Which of the following is not correct regarding the cell-free fetal DNA? Is not correct. Sensitivity, yes, it is correct. Sample taken before 10 weeks, that is wrong. Because we usually do from 10 weeks to 40 weeks. Before 10 weeks, the maternal blood, which the content of the fetal free DNA is low. Therefore, the sensitivity is less to detect those things. Therefore, we do after 10 weeks. Major risk factors for preeclampsia, type 1, yes. Chronic hypertension, yes. CKD, yes. Age more than 40, yes. It is a minor risk factor. There should be 2 minor risk factors to start aspirin. Major risk factors for SGA, maternal age more than, yes. Previous SGA, yes. Paternal SGA, yes. And IVF pregnancy, it is a minor risk factor. DVT, I think it is excessive alcohol intake. You can drink more alcohol, no question, DVT. Booking visit OGT is not indicated. It's grand multi. If the BMI is 30, we have to do it. Age more than 40, we have to do it. Previous history of large baby, yes, we have to do it. Following measures are taken for the prevention of preterm labor. As I told you, we use micronized progesterone, cervical circlage, and we go for screening and all of the above. First trimester ultrasound scan is useful to screen for aneuploidy, yes. To screen for preterm labor, yes. Thorough screen for risk of to screen for risk of preeclampsia, yes. All of the above. Thank you. And give me 1 minute. I would like to. I think all are maybe hungry. Give me 1 minute. I would like to thank first my team who was dedicated to organize this event, Obstetrician and Gynecology team. And I would like to thank Clinical Society who giving me this opportunity and conducting this wonderful job, conducting this type of lectures and giving the opportunity for the doctors to have increase their knowledge. And especially thanks goes to our sponsors. Willingly they support this event and they sponsor the whole event without any hesitation. Thank you all. And all the participants who gathered here to glamour the event. Thank you all. And I get this opportunity to thank you all because this may be my last address for this type of huge crowd. And I worked here for 4 years and I got immense support from the peripheral doctors, MOH and everyone. Therefore, thank you all for letting us, giving me support to give the good health care to the community. Thank you.
Thank you, sir. We would appreciate if you could take few seconds to provide your valuable